Hello and welcome to the 136th episode of the Hope Illuminated podcast, where we share powerful stories, science, and well-being strategies. Here, isolation and despair can be defeated and a passion for living rekindled. No flashlight required for our journey, just fired up listeners ready to gain guidance from myself and some international experts. Today, we're going to have a very important conversation about firearm safety in the home. And I'm joined today by Rinad Beidas, and we met at the International Association of Suicide Research Conference in Barcelona about a year ago right now, around this time. And I was just so impressed and inspired by your research, Rinad, and the implications of really making a difference with a scalable intervention. Welcome to the show.
Thank you so much for having me.
Yeah. So before we dive into all of this, just a little context of why I care so much about it. And that is because we know that about somewhere in the vicinity, about 82% of kids who die by suicide with a firearm got that firearm from a friend or family member. And for someone like me who did not grow up in a firearm owning community or firearm culture, I get at a loss sometimes about how to make a difference or how to even talk about these things in our communities where firearm ownership is such an important and core value. So we need interventions here that will really make a difference and come alongside people in a collaborative and respectful way to really underscore the importance of safety. And so that's what we're here to talk about. But before we get there, Rinad, what is the reason why you care so much about this topic?
Thanks for asking that question. I think it's really important to kind of articulate the why of the work that we do. So we have a family member who died by suicide with a firearm. And this work is really in memory and in honor of him. And in the hopes that we can have impact and ensure that other families don't experience the same tragedy and pain that our family experienced.
Thank you for sharing that. And, like you, I've been turning our pain into purpose as well. I think that's sometimes the only way that we get through this is we try to figure out what's mine to do. And whether you're a researcher or a clinician or an advocate, there's lots of work to be done here. So thank you for championing this particular part of the suicide prevention conversation forward, because it's difficult. And I think a lot of people shy away from it because it can get so divisive and just challenging to try to figure out, what are we going to do here? I mean, I think everybody can agree nobody wants anyone to die by suicide, but on this particular note, it can take a lot of different directions that keep us stuck. So, what helped you think about this particular way of making a difference in the space of firearm safety when it comes to suicide prevention, and what fuels your why today?
To take a step back, I'm an implementation scientist, and I feel like that's really important context for the audience to hear, to better understand kind of why I took the approach that I took and what fuels my why. And implementation science boils down to science focused on closing the gap between what we know we should be doing and what we actually do in the context of clinical practice and community and schools. So that is really the larger kind of umbrella of the portfolio of work that I've been doing for the past 20 years. And so I tend to pick my no-do gap questions based on those where I think the work can have the biggest impact and what I find kind of personally meaningful and what kind of drives me to get up in the morning. And so, after experiencing this loss in our family, I also happen to have just had my first son. And we were at the pediatrician's appointment at the 6-week well child visit. And they were asking me all these questions about, how the baby slept and whether or not we had a smoke alarm, all the anticipatory guidance safety questions that pediatricians ask parents. And I had this light bulb moment of, I don't think my pediatrician asked me any questions about whether or not we had a firearm in the home and whether it was secured in a manner that would reduce unauthorized access. And so that kind of light bulb moment, combined with my knowledge of implementation science brought together and kind of being connected with the right colleagues and in the right space allowed me to pursue this question. And so what I came to understand is that there is, in fact, a no-do gap as it relates to the implementation of secure firearm storage programs in pediatric primary care. There's actually an evidence-based practice that was tested in a large trial by Dr. Sherry Barkin and colleagues, published in Pediatrics in the 2000s, focused on testing the effectiveness of an evidence-based program in impacting parent storage behavior. And that study showed across a number of representative practices across the US that parents who received the evidence-based practice were more likely to report more secure storage compared to parents who were in the control condition. So we really picked up from there. So there was already this existing program. It was actually part of a larger bundle of violence prevention strategies. We took just the focus on firearms kind of out of the program. And then we spent years, working with affected constituents to better understand how we could ensure that the program would be as acceptable as possible and highly implementable and scalable within the context of pediatric primary care. And so that means that it has to be really short, and it has to be respectful and acknowledging rights of firearm owners and not put parents in a defensive stance, and that it really needed to be a universal approach, a population health strategy for suicide prevention. And so once we kind of did the adaptation work that we needed, and we understood from different constituents what it would take to implement this scalable program, that we were ready to do a large scale implementation science trial, in line with actually what's been called out in the Surgeon General advisory. If you take a look at the 2024 advisory, the Surgeon General explicitly calls out the need for moving beyond descriptive studies of firearm injury mortality and actually doing these large-scale implementation trials. So we think this is a really good example of that.
So much I want to unpack there. I don't even know where to start. But I think what I would like to have you unpack first, because for some of our listeners, it's the first time they've ever heard this phrase, implementation science. And for me, it's super exciting because I get to go to these research conferences, hear all of this amazing work academics are doing. But in my heart, I'm also sad because sometimes they never leave the peer-reviewed journal article and academic realm to get into the hands of people who can actually make a difference with the people in the community. And that is just such a frustrating thing for someone like me who knows all the things, but can't, or just... There just needs to be more of that translation into, okay, so now what? What do we do? So can you talk a little bit about the basic tenets and pillars of implementation science, and how do we solve that no-do gap?
Yeah. I mean, implementation science is all about the so what. So one kind of foundational piece to implementation science is really taking a community engaged approach in all of your activities. And so that includes the development of the actual programs and interventions that we want to deploy in the real world setting. And side note, I personally believe that we should be testing and developing all the things that we think we should be doing in the actual settings in which they're intended to be delivered. I think there's been a real kind of challenge where we've developed these interventions and tested them in settings that don't look like the real world. And that creates this gap. Right. But even if we did in vivo testing, co-creation of programs and interventions within context, it's still likely that to support implementation, we're going to need a science to think about how to overcome the multi-level factors that make it hard for us to do the highest quality, best access care for everybody. And so one of the things I like to say about implementation science for folks to understand what we actually do is to think about implementation scientists like detectives or even like consultants. So we go into a context, we try to understand that context, the people who are delivering care, the end users who receive the context. And then we understand that to ultimately have success, there's an important kind of pre-implementation process that needs to be attended to. You can't just dump a new program in a setting and be like, do that, and then walk away. That doesn't work. You have to understand Are the clinicians excited about this? Do they need help and support in implementing it? Do they need training? Do they need prompts to remind them? How are the clients or the patients going to react to receiving this thing? We call them things because that reflects programs, policies, all the potential evidence-based things we might want to be implementing. Is the context, does the organization support the delivery of that thing? Are there policies in place? Did the leadership explicitly state, yes, clinicians should be doing this thing? And then how does the broader sociopolitical context affect implementation? And so we go into a setting, we think about the thing that we're trying to deploy, the people who are going to deploy it, the setting in which they're going to deploy, and then we use different strategies to support potential barriers that might come up in the deployment process. And then we aim to understand the success of our efforts. So we evaluate in an ongoing iterative way and pivot our approach as needed in partnership with the affected constituents to ensure maximal success. And I actually think that the Aspire trial, which is the culmination of all that initial pre-implementation work we did that I described earlier, is a really good example of how we followed the steps of the implementation process to result in a successful implementation. And I'm happy to talk about that more, but I know you have a lot of questions, so I don't want to jump into that just yet.
Well, and I think the other piece that is key in that implementation chain is the buy-in of the people delivering the intervention. So for example, I always bring up like universal screening for suicide sounds great. Yep, we have lots of evidence that shows screening helps move people. But what I've found in some settings, my husband's a veteran, and every time he goes into the VA to get something in his foot checked or get his blood pressure checked or whatever, he gets asked about suicide like 5 or 6 different times as he goes from provider to provider. And he's so over it. He's like, I'm not going to tell them if I ever am or not. I'm just so irritated. Right. So I think because they don't care, the people asking the questions are so numb to it now, they're not expressing that, important, authentic alliance and compassionate curiosity. They're just checking a box. So I think there's also this other piece of making sure that there's the buy-in, people understand the why, because healthcare providers and educators, they are constantly getting more on their plate. And it's easy to understand that frustration of like, just one more Thin Mint, just like squeeze it in there. You can do it.
I couldn't agree more. That buy-in is part of those multi-level factors at the clinician, at the client level. And you're totally right. We just keep adding to people's plates. And there's also this whole area in implementation about de-implementation. How can we take things off the plates? How can we be smarter to make the right choice, the easy choice for clinicians, for patients and clients? So it is really about this thoughtful redesign. And it's not just about adding more and more programs.
All right. So thank you to all the listeners who had no interest in implementation science and really just want to know how to keep kids safe. But I think this is all part of the problem that we are trying to solve. So let's shift gears and talk a little bit more about pediatricians and home safety for kids. So what did you design and what did you learn and what does it mean to our pediatricians and parents in our listenership?
Yeah, so I think there's never been a more important moment when pediatricians can play a role alongside parents and other affected constituents to keep young people safe. We know that firearm injury is now the leading cause of death for young people in the United States. There's a Surgeon General advisory, and we need scalable, universal population health strategies that all affected parties find acceptable. And I think evidence-based secure firearm storage programs within the pediatric primary care setting is one way to achieve this. Now, when we think about how we
Oh, I just want to jump in and make sure our listeners did not miss, because I want you to say it again. Firearms is the leading cause of death for our young people. To what degree? And who said that?
There's a recent publication using the Centers for Disease Control data in the New England Journal of Medicine by Dr. Jason Goldstick and colleagues that demonstrates that somewhere around 2020, firearm injury took over as the leading cause of death for young people, overtaking motor vehicle accidents. But one of the reasons I think this is so important is because motor vehicle accidents are actually a success story from a public health perspective, because we were able to take something that was a too commonplace occurrence and reduce it using a public health approach. Seat belts being a major driver in the reduction of injury and mortality from motor vehicle accidents. No one took away cars. We just made cars more safe for young people. And so I think it's a really good example of how we can take a public health approach to address a public health problem. And I really like secure storage, a secure storage focus, because it really is a non-political, evidence-based approach. Everybody agrees that young people should not have access to firearms in an unauthorized manner. All major professional organizations agree upon that, including the National Shooting Sports Foundation, the American Academy of Pediatrics. And so we really can all get behind this shared mission to keep young people safe.
Fantastic. And we'll put all of these citations in the show notes in case you want to do a deeper dive into those pieces of research. All right, back to your study.
Yes.
What'd you do? What'd you find?
So we spent a good amount of time in collaboration with constituents from lots of different groups to better understand their perspectives on how we could implement this already existing evidence-based program in pediatric primary care. And so there was a lot of work leading up to the trial, which I'm going to describe now. And I just think it's important to call that out, because it's not a scenario where necessarily every setting can just plug and play what we did and have the same results, because that engaged, partnered approach was a big part of it, and that pre-implementation process. And so I just always want to call that out. And so this work was in partnership with two large health systems, Kaiser Permanente, Colorado, and Henry Ford Health in Michigan. And essentially what we did was test two different approaches to close that no-do gap that I was talking about. So we know that generally pediatricians do not engage in the two components of the evidence-based secure firearm storage program that we were testing, which is having a brief conversation with parents about the importance of secure storage and offering a free locking device. Those are the two pieces that we want pediatricians to be doing. Based on our survey work, it looks like about 2% or fewer of clinicians do that in practice with patients that come in for their well child visits. So it's very, very low. And I also want to call out that the American Academy of Pediatrics, which is the organization that supports pediatricians, has put out recommendations, guidelines, suggesting that pediatricians should be doing this. So it's not like I just said this is something pediatricians should be doing. There's a broader outer setting support for this recommendation. So based on all of our pre-implementation work, we were interested in testing two different approaches. The first approach we did, we call the nudge arm, is we made a change to the well visit EHR electronic health record template. So all pediatricians use this documentation to help guide the flow of the visit. So we really wanted to incorporate it into the visit workflow. And we just added in the section where pediatricians ask about other safety related matters, two items. One was a reminder to have the conversation about secure firearm storage, and the other was a reminder to offer a cable lock, which was the lock that was made available through this study. So we had 15 clinics who just had that change in the template for all of the clinicians who are providing services to young people and their families. And then the other 15 clinics got that change to their electronic health record template, as well as something called facilitation. Facilitation is kind of like consultation. Essentially, there was a health system employee who worked with clinic staff and champions to problem solve around things that came up in the deployment of the intervention. Like, where do you store the locks? There's a lot of locks that they have to keep in place. Do you put the locks out in a basket in the room, like conceptualize, like putting condoms in a basket in a bathroom so people can take as many as they need? Or do you store it behind a kind of locked area and take it out for each family? All kinds of questions that can come up. And so we had a facilitator who spent a little bit less than an hour a month supporting those clinics in problem solving the deployment of the program. And what we found is really remarkable. So there were almost 50,000 well child visits across the year of this trial. And when you looked at the clinics that got the change to electronic health record and the facilitation, kids and families presenting to those clinics were 2.2 2.2 more times more likely to receive the program than young people and families presenting to the clinics who just got the electronic health record change. And so what that means is 49%, almost half of the kids who went to well child visits in the arm with the facilitation got the whole program, both the conversation and the offer of the lock, versus 22% of kids who were just in the electronic health record clinic arm. And remember, at baseline, we're only at about 2% where pediatricians are doing this. So this is really robust practice change. And to go from 2% to almost 50% is really nothing short of remarkable. And we're really proud of that. And we believe that it has the potential for saving lives and keeping young people safe.
Well, that was going to be my next question. Well, first of all, amazing, like huge uptick. And it makes sense, right? When people have barriers and they got no one to bounce the barriers off, they abandon the practice. It's just too much to figure out. I got a whole bunch of other things to figure out. I'm not doing it. So it really makes sense. And less than an hour a month is nothing. It's nothing in the scheme of things to save a kid's life. Is there a plan to do any longitudinal studying of the kids who got the intervention? Yeah. Can you tell us about that? Because that's really where the rubber meets the road.
Yeah. So I think there's a couple places where the rubber meets the road. First of all, this was just for the first year. What does that sustain? So we actually have a analysis that's ongoing that we'll be publishing, looking at whether or not that huge uptick in provider behavior change sustained over time, because that's a huge challenge that we have. So that's one thing that we really need to get out in the world. The second thing is also just the more kind of the story of how this was implemented, what providers thought of it, what families thought of it. That's also work that we have planned. Now, to look at outcomes related to firearm injury mortality, fortunately, the prevalence is so low that we're not able to look at it in the way that you were just describing. We would need to do it at a larger scale. Now, you're listeners, you're not readers. I'm so used to audience reading. Listeners, I don't mean that this isn't an important thing. One life lost is one life too many, right? But from a statistical power perspective, we are not able to analyze whether or not this results in saved lives for this particular study.
Although you could get on that track soon, right? You did 50,000 well child checks in 1 year. As this scales, the numbers are going to increase exponentially. Exactly. Unfortunately, it's also a long longitudinal, because these are probably babies, toddlers, school-age children.
Our age range was 5 to 17. Yes, okay. Absolutely. We can evaluate this as the sample size grows over the years, but I personally would like to do this nationally and at scale to really answer the question. This is a question everyone asks. Okay, great. You got doctors to do it, but does it actually save lives? We are doing some simulation to kind of help people understand the number of people that a doctor would need to talk to save a life based on the simulation data from the Monito et al. Paper in 2019, which demonstrated that even a modest increase in secure firearm storage behavior nationally could result in up to 32% of saved lives. And so we are looking at it in multiple ways to be able to answer that question, but to truly answer that question in the way that my scientist's heart wants us to, we need to do a larger scale national implementation. We're also doing a new study that we were just funded by the National Institute of Nursing Research. The study I was just speaking about is funded by the National Institute of Mental Health. This new study is going to take what we did in these two health systems and to adapt the program and implement it in health centers, which are safety net settings across the state of Illinois. So that'll be another opportunity as well to start to continue to unpack that really important question that you asked.
Right. And given the amount of research we have in lethal means safety in general, and then firearm safety specifically, I have all the hope in the world that this is really going to help us save lives and prevent youth suicide, as well as other kinds of youth firearm death.
Absolutely. I think there's a lot of interesting question. I mean, this particular program is explicitly meant for suicide and unintentional injury. And I'd love to be able to look at if there are downstream effects on other types of firearm injury and mortality as well, but we don't know the answer to that question right now.
Excellent. Well, let's just do some real tangible takeaways for the pediatricians and the parents out there, given what you're learning so far, given their high concern for kids' well-being, what are some absolutely concrete things they can do today to help keep the safety of children that they are in custody of?
Yeah. So for pediatricians, we have a brief, low-cost, scalable way for you to talk to parents about the importance of secure firearm storage. Not all pediatricians will have access to free cable locks in the way that we were able to make available through this study. Some states actually make cable locks available to community-based organizations. Like in Illinois, there's actually an appropriation for that. So community-based organizations can get those locks for free. There is a really healthy discourse in the literature and in the field about the types of locking devices. We didn't get into that together today. For example, there are preferences for biometric safes versus the cable locks that we distributed in our study. But I believe that the actual act of a doctor giving a family member something tangible to use signals the importance, because we don't really get other things from the doctor's office like that, right? I don't get like a helmet. They don't hand me a smoke detector. Like the expectation is that I go kind of do that as a parent. So if your doctor gives you something, it just signals this really matters. We think that that's really important. We have resources available that clinicians can look at if they want guides to help them talk about secure firearm storage. And that's all freely available. But the takeaway is, please, pediatricians, talk to your parents and young people about the importance of secure firearm storage in a respectful manner that joins and allows for folks to be open to that conversation.
Yeah, and troubleshoot wherever they have issues, or just have it be a conversation. So I want to just take that, how do we access the locking piece one step further? If people say are not in Illinois, what
Sure.
should they do to try to figure out how to get these locking devices, whether it's biometric or cable, into their homes? What's the best way for them to do that?
So I'll answer that in a few different ways. But the first is that actually there is a project called Project Child Safe that's supported by the National Shooting Sports Foundation. And it is a national effort that's been going on for many years that makes cable locks freely available through police departments across the country. So that is always an option. And if you Google and look up Project Child Safe, you'll be able to identify places where you can go. I've also seen communities use fundraising as a way to identify philanthropic donations to cover the costs of cable locks. Hopefully in the future, there'll be more mechanisms for covering the cost of these devices, even like the doctor can write a prescription for a lockbox as a universal strategy for reduction of injury and mortality. So I think both for pediatricians and clinics that are interested in doing this, and parents, you can go directly to your nearest police station and request these cable locks if you'd like. And then some states also have laws about those locks being given out at the point of purchase. So there's multiple mechanisms through which to get the cable locks. But again, there's an increasing understanding that the locking kind of storage boxes are the preferred mechanism, and we need a better understanding of how to give those out at scale. I will say that the University of Washington, Seattle Children's has been doing some really nice community facing work and giving out lock boxes at scale. So that's a good lead. For parents,
One more thing there, because
sure.
For all of my suicide prevention advocates out there, this is a great thing to do for your community, is buy a whole bunch. And I've even seen them branded with 988 or some
Sure.
other hotline number that, again, any psychological or physical barrier that we can slow people down or get them thinking, okay, that might be a sign, or whatever it is, helps us in this endeavor. So if you have grant money that you can allocate towards this, or fundraising that you can dedicate towards this is a great concrete thing you can do that might have some more value than just extra stickers and posters and t-shirts, which is what we usually spend our money on. So just to get another way to serve the community. Okay, now back to you, parents.
And, really the premise here is anytime you can put time and space in between, somebody having suicidal ideation and engaging in a behavior that could be lethal is the goal here. So that's just really important. One more thing for pediatricians, we really recommend, and this dovetails on my comment about it being respectful, that you take a harm reduction approach when talking to families about secure firearm storage. So for a long time, we've taken the stance that either the only safe home is a home without a gun, or that it has to be stored with the ammunition stored in a separate place locked and the gun unloaded stored in a separate place locked. And while that is the most secure way, it also doesn't acknowledge the fact that every family has different reasons for having a firearm and that we need to meet people where they are. And the goal is to move towards more secure firearm storage behavior as much as possible. And also that firearm storage behavior is dynamic, right? I might have my gun in my car on my way to go hunting, and then I have to come home and store it, but I may also have a firearm for protection, and I may store that separately. I may be more comfortable storing that in a biometric safe loaded and that's better than storing it under my bed or next to my bed in a cabinet that can be open that's unlocked. So that's just really, really important for me to make sure that part is heard. And then for parents, really thinking thoughtfully and committing to how you're going to secure your firearms is very important. We also know a lot of people bought firearms in COVID that hadn't had kind of formal safety course instruction around how best to store the firearms to ensure that unauthorized access doesn't happen. So definitely encourage parents to understand all the options available to them. And that really the goal here is for us all to come together and to keep young people safe and alive, and to partner with folks who share that goal, and to really think about all the firearms in your home, how you can store it in the most secure way to ensure that tragedy doesn't happen.
And if parents want that safe storage kind of training, do you have a recommendation on where they should look?
That's a great question. There's a lot of options available, and I would be happy to get back to you after this podcast to share some resources, if that's helpful.
Yeah, sure. And again, we're going to be compiling. There's a lot of good things here, whether you're a researcher, a pediatrician, or a parent, a lot of good things she's bringing forward. We're going to put as much of this as we can into the show notes so you can come back and just kind of check these things out as a follow-up. I'm going to go, anything else for the parents? Okay, I'm going to go back and do a quick recap, and then I'm going to come back to you for your final thoughts, your one or two things that you want to make sure does not get missed from our listeners. So I'm here talking with Rinad Beidas, and she is an expert researcher in implementation science, specifically around safe storage of firearms and in an intervention that's brief and scalable for pediatricians to have respectful and collaborative conversations with parents on how to keep kids safe from a firearm death. And I think we can all agree, all of us, that is worth preventing. And so the kind of intervention she's developing and implementing really has to work for the pediatrician. It has to work for the system, the hospital, or the clinic. It has to work for a lot of things. And we really need to get the buy-in for the importance of this to squeeze yet another thing into a physician's 5 minutes that they often have with the families. But it's so important, and possibly the most important, because as we emphasized, firearm death is the leading cause of youth death in our country. And so this is a really important thing for us to focus on. And we can do this no matter what our views or guns are. We can all do this. And we talked about the importance of not only having a conversation and creating a plan, but also delivering some kind of locking device, whether it's biometric or cable, both to emphasize the importance of it and to reduce one more barrier. People don't know where to look. They don't know what to buy. It's another cost, et cetera, et cetera. So having the physician give that, again, increases the likelihood that it's actually going to be used. And I am personally really looking forward to the long tail of your work here about how this gets scaled. What is the story of how people experience on both sides, the doctor and the family? And then eventually to have that really yay moment, because I know it's coming, because I truly believe this is going to have the impact that we're all hoping for of reduced youth suicide. So much here, such a rewarding conversation for me. I'm always looking for things that actually work, not just sound good. And I really believe this is a big lever that we can pull. So what are one or two things that you want to make sure that everybody walks away with?
Well, you said it so beautifully. It's hard to follow up on that articulation. I think one thing is I just want to call out what a team effort this was. I'm here talking about the work of a village of people, and it's just really important for me to recognize. I could spend the whole hour saying all their names, but I won't. But this really is the work of a team. It's not my work alone. The second is that the implementation process must be attended to as you consider implementing, brief, universal, scalable approaches to suicide prevention. There is a science behind it, and encourage folks to use that science to maximize the likelihood of success. And then probably the third is, we have something we can do now. So let's do it. And as the science evolves, we'll continue to iterate our approaches. I really hope that this work gets picked up by other health systems, and it's already happening. It's been really wonderful, the kind of outreach and interest in this work over the past few years. And so I think there's a real opportunity and kind of movement here in terms of something that is evidence-based, scalable, non-political, that we can do to keep young people and adults safe.
Oh, that's right. We didn't even mention that. The added benefit of the other adults in the house, or
Right.
all the adults in the house.
Right.
This also works for them as well. And they are actually more likely to die by suicide with a firearm. Thank you so much for your time, your passion, your expertise in this amazing intervention. Ned, if people want to connect with you, what's the best way for them to get a hold of you?
They can email me. We also have a website, safefirearm.org, that I'll make sure that you have for the listeners. So those would be the best ways to find me.
Awesome. Well, I hope our paths continue to cross and that I get to benefit from all of the things that you and your team are learning. Thank you so much to our team. We also have a village behind all of this effort. Mitchell, Chase, Dave, Whitney, Elias, all kinds of efforts behind the scenes to really make sure that this sounds good and gets out to all the ears that would benefit from hearing it. And thank you to all the listeners who made this time today to lean into this important conversation about firearm safety. So in closing, open your heart, challenge your thinking, and take action to save lives. Together, we can restore dignity and sustain a passion for living.